need more. We definitely need more representation in our group, native representation in our group. I feel like sometimes we have a long way to go when it comes to, really engaging tribal nations and, our tribal organizations in the work of epidemiology. But we're getting there, and it's great. I just finished teaching my first field epidemiology course at the University of Buffalo, and all of my students signed up to be members of CSTE, and I just thought that was great. So we're going to have to be a little tricky here, and because I'm going to work for my presentation, so I'm not going to be able to see everybody on Zoom. So we're on the second slide. Let's go to the third slide. So are we on the third slide?
Yes, sir.
Okay, let's go. So the National Indian Health Board, great organization, very proud to be a member, have been working with the NIHB, man, when there was probably only a handful of employees, at least, probably over 20 years ago. Established by our tribal nations in 1972 to advocate as the unified voice of federally recognized American Indian Alaska Native tribes. NIHB is located in Washington, D.C. on Capitol Hill, which is great for us. Fourth slide, please. The National Indian Health Board, NIHB, is a 501c3 charitable organization that seeks to reinforce tribal sovereignty, strengthen tribal health systems, secure resources, and build capacity to achieve the highest level of health and well-being for all federally recognized American Indian, Alaska Native tribal nations, populations, and communities. NIHB is the only national organization of its kind serving all federally recognized tribes and advocating on all issues related to health and public health in Indian country. NIHB provides policy analysis and real-time communications to tribes throughout Indian country in partnership with its members. And those are the area Indian health boards, and in places where no health boards exist, with our tribal nations, regions, and communities. Slide 5, please. So what is epidemiology? And we're going to get down to the basics here, and we're gonna, this is really the foundation for the work that we do in outbreak response, the work we do to address infectious diseases. Epidemiology is the methods used to find the cause of health outcomes and diseases in populations. So epidemiology is the study that is scientific, systematic, and data-driven of the distribution, and that's like the frequency and pattern, and determinants, which is the cause and risk factors of health-related states and events, not just diseases, and specified populations. Those could be neighborhoods, schools, our cities, our urban Indian populations, our states, our tribal nations, our countries, throughout the whole globe. It is also the application of the study to the control of health problems. We use data to paint a picture of the disease distribution. 6th slide, please. Solving health problems. To solve health problems, epidemiology practitioners or epidemiologists use a 4-step scientific approach that includes data collection, assessment, hypothesis testing, and action. When using the scientific approach, data are collected and an initial assessment or hypothesis is conducted. The hypothesis is then tested.
You want me to sit around here? No, I was just
Hello, we can hear you. Please mute your phones or mute your microphones. Thank you. So I want to direct everybody to the far right. This portion of solving health Hello, are we having problems? Adriana, are we okay?
Yes, sir. Can you see my screen?
No, I can now. Like I said, I'm really presenting from my,
Okay.
we're
We
good.
can-
Yep, I'm on that
Yeah.
slide. Okay, everybody, if you're on, please mute your phones. Okay, so we're on solving health problems. I wanted to direct everybody to the far right. First, data are collected about health problems occurring among the population through public health surveillance. The data collected include information about when the problem occurred, as well as where and who were affected. That is time, place, and person. This is known as descriptive epidemiology, and it will be covered in greater detail later in this presentation. The next step, the epidemiologist establishes inferences on the basis of the collected data and draws initial conclusions on the basis of those data. From there, he or she uses the information to generate hypotheses about what might be causing the health problem. Third, then, how and why of a condition is determined by conducting tests or studies to determine if the hypothesis is accurate. This determination of how and why is known as analytic epidemiology, which we will also cover later in this presentation. Finally, the epidemiologist takes action. In public health, that action is known as intervention. We take actions to intervene, prevent the condition from spreading further or to promote healthy behaviors. The epidemiologist recommends or implements some form of action at the population level, for example, or community level. A good example of a quick intervention to the pandemic was masking and safe social distancing. Those were quick interventions to show action that we're responding to the health problem. Some terms to know. Next slide, please. Slide 7. Terms to know. The epidemic is the outbreak or occurrence of one specific disease from a single source in a group, population, community, or geographical area in excess of the usual level of expectancy. The pandemic is the epidemic that is widespread across a country, continent, or large populace, and possibly worldwide, as we've seen with COVID-19. And the incidence is the extent that people within a population who do not have a disease develop the disease during a specific time period. Next slide. Slide 8. Terms to know: prevalence, the number of people within a population who have a certain disease at a given point in time. Point prevalence, how many cases of a disease exist in a group of people at that moment. And prevalence relies on two factors: how many people have had the disease in the past and the duration of the disease in the population. Two very, very important points regarding prevalence. Next slide. The uses of data in public health. Data and the results of data analysis have many uses in public health practice. These include, but are not limited to, population or community health assessments, public health surveillance, disease investigation, prevention and control measures, evaluation, program planning, and future needs assessments. Next slide, slide 10. Possible data sources. Focusing on data helps separate what is thought to be happening from what is really happening. It is important to use credible data. CDC and IHS publish data sets on surveillance data, health-related surveys, vital statistics, and outbreak investigations. The American Hospital Association publishes data on hospitals and health surveys. Healthdata.gov aggregates a few government health data resources and has an easy to navigate system for finding data on specific topics. Your state or tribal health departments may have a data portal or dashboard with public data to community health assessments, public and population health data sets. And I want to emphasize this, this is level of importance, and I'm sure Colin can speak to this as well as many others on this call, or this training. Utilize our tribal epicenters in your region to address the widespread American Indian, Alaska Native data deficiencies. In 1996, the Indian Health Service established tribal epicenters, and we call them techs. Today, there are 12 techs that can access data from the Department of Health and Human Services, including data from HHS, the Centers for Disease Control and Prevention, and the Indian Health Service. Your tech can help your tribe, your tribal clinic, your hospital, to monitor the spread of infectious diseases such as COVID-19 and conduct other analyses that support public health decision-making for your tribal nations, your communities, within your tribal organizations. Next slide, please, 11. But all data has limitations, and this is the big challenge for us in public health, especially us working in Indian country. Tribal public health authorities, and particularly, report extensive difficulties with data sharing by state and local public health authorities. This is largely due to states having different laws about public health data sharing. This decentralized system in the US made it harder for the nation to respond to COVID-19. Likewise, most tribal clinics do report noticeable diseases to state health authorities to facilitate epidemiologic surveillance. But data is not always well defined. There's no standard way to report test results, infections, or even deaths due to COVID-19. Since each state made its own rules for COVID-19 reporting, it made it harder for CDC to correctly combine data from the different states. Many state health departments do not collect data or assess by racial ethnic group. And this is alarming. You know, and a lot of the work that I've been doing recently, and when I was a CDC health scientist for 20 years, I think this is something that we preached right from the beginning, and that pushing our pushing our state health departments to collect data by racial ethnic group. And data may be missing or misclassified. This is not uncommon. In a report titled Racial Misclassification of American Indian and Alaska Natives by the Indian Health Service Health Service Delivery Area, a report or a publication in APHA that I happen to be a co-author on. Melissa Jim, one of my colleagues from CDC, and her team found that nearly 30% of American Indian Alaska Native person death certificates misclassified their race, and that hospital inpatient discharge records have nearly a 50% rate of racial misclassification for American Indian Alaska Native individuals. This is huge in itself. I mean, this is a health disparity in itself, the issue of racial misclassification with our tribal people. Slide 12, please. So how do we summarize public health data? Slide 13, please. Okay, so we have ratios and proportions. Ratios are just expressions that compare quantities. For example, a physician reports they have 10 female and 5 male patients. What is the ratio of female to male patients? You could say that the ratio of females to males is 10 to 5, or you can write this as a fraction, as 10 over 5, or you can write it out as 10 to 5, right? A proportion is a type of a ratio. You might use a proportion to describe what fraction of a clinic's patients tested positive for COVID-19. A proportion may be expressed as a decimal, a fraction, or a percentage. All right. So in this example, we have the number of people with the characteristic population in a specific time period over the total number of people in a population in a specific time period multiplied by 100. Slide 14, please. So in this example, in 2022, in a population of 5,000, 3,000 identified as American Indian Alaska Native. So you'd have 3,000 people identified as American Indian Alaska Native in 2022 over the denominator of 5,000 people in a population in 2022 times 100. And that would give us 60% of the population identified as American Indian Alaska Native. Next slide, please. Slide 15, rates. And to be honest with you, rates, I like using rates as an epidemiologist because I feel it gives a good indicator of the health problem or disparity when you're comparing populations. A rate is often a proportion defined as a frequency of events that occur in a defined time period, divided by the average population of risk. A rate represents the burden of disease or other health-related outcome during a specific time period, usually multiplied by 100 or 1,000 or 100,000, depending on the size of the population. Proportions and rates are used in public health for qualifying morbidity and mortality. Some measures of morbidity or illness include prevalence and incidence rates. Measures of mortality include mortality rates, and measures of disease severity include case fatality. Using the same fraction from the proportion formula, if you multiply by 1,000 or 100,000, each has a little different meaning in the proportion. Slide 16, please. Public health frequency measures. Mortality, all in a specific time period, excuse me. So the crude mortality rate, the numerator is the total deaths from all diseases. The denominator is the estimated population size, and the multiplier is 1,000 or 100,000. Proportionate mortality, again, the numerator is the total deaths from a specific disease, and the denominator is the total deaths from all diseases multiplied by 100. The case fatality is the total deaths from a specific disease, that's the numerator, divided by the denominator, total cases of a specific disease, and then multiplied by 100. The crude mortality rate can make restrict to disease-specific, age-specific, or race-specific rates. Slide 17. So our interactive example, example in a population of 5,000 people, 20 tested positive for influenza in the week ending 12/4/2022. So we use 20 people tested positive for the flu in the week ending December 4th, 2022, out of 5,000 people in the population in that week ending on December 4th, 2022 times 1,000. And that equals 4 cases of COVID-19 per 100,000 persons in the week ending on December 4th, 2022. But more than just a proportion of the whole, conceptually relates people with characteristics to the population size in that time period. Next slide. Incidence. So incidence represents the risk of developing a disease, can also be a rate and show how quickly a disease is occurring in a population. More commonly expressed per 1,000 per or 100,000. Unlike prevalence, incidence only includes new cases, not existing ones. And ideally, people who are currently sick should not be included in the denominator. And this is extremely challenging in the field, so the average population size can be used in in place. So incidence is just the new cases. So it's the number of new cases of a disease in a specific time period over the average population count in that specific time period times 1,000 or 100,000, depending upon the size of the population. So which city is at greater risk? Okay, city A, city B, we have cases of 20 in both, divided by the total population of 1,000 in city A and divided by 5,000 in city B. Number of cases, the total population, and the incident rates. And using the rates to make comparisons, we need to account for the fact that the number of health events depends in part on the number of people in the community. And looking at this table of surveillance data, if city A and city B had 20 new cases of COVID-19 reported today, which city is at greater risk burden? Okay. Slide 20, please. Next slide. The answer, if you chose city A, you were right. So in this table of surveillance data, if you have 1,000 people in your community and 20 cases of COVID-19, that would be a lot more significant than if you had 5,000 people in your city and 20 cases of COVID-19. Furthermore, suppose that all 20 cases in either population occur within only one age group, race, or gender. In that case, this might influence your decision to investigate further. So for example, city A has a greater risk of COVID-19 compared to city B. COVID-19 is occurring in a faster rate in city A compared to city B. Very significant. Affects which community needs the most help. Would use a longer time period to determine this. We could take this one step further. What if 18 of 20 cases in community A identified as American Indian Alaska Native? And what if all 18 were assigned female at birth? You would want to target these population subgroups as they are most affected by COVID-19 here. Gives further attention to possible health disparities. Slide 21, next slide. So public health significance, proportions and rates. Proportions, easy for anyone to understand. 28% of the deaths in the US were caused by heart disease in 2003. Proportions show who is affected by a health problem, can describe how much a population currently has the disease, and can indicate how many deaths in a community were caused by that disease. And that is easy for anyone to understand. Let me reiterate that 28% of deaths in the US were caused by heart disease in 2003. Rates show who is affected by a health problem and how rapidly it's occurring in the population. Standard way to compare characteristics between populations of different compositions. So the example is examples include sizes, racial makeup, age distribution, locations, time periods. Next slide, please. So with all this data, how do we present it? Next slide. So we speak with numbers. Your goal is to turn complex data sets into simple messages. Next slide, 24. So how to present data visually. Remember, a simple, clean display is better than something cluttered. Again, speak with numbers, but keep it simple. Highlight key facts and figures. Visualizations can be used to illustrate endless types of data. Popular types of data visualizations include tables, graphs, charts, maps, dashboards, and infographics. A picture is worth 1,000 words, and most people process and recognize patterns and visuals more quickly than from text. We visualize our data to tell a story. Data can tell us deaths from a disease, new cases of disease over time, trends, usefulness of new treatment or preventive methods, and demographics, age, sex, gender, etc. So next slide. When to use a table. To use a table to look up specific values, compare specific values, display precise values, and communicate more than one unit of measure. Next slide, slide 26. When to use a graph. To choose the proper graph based on the data and function of the chart. We use it to show patterns, to show trends, to show exceptions, and to reveal relationships among multiple values. Next slide, when to use a line chart. Line charts are used to track changes over short and long periods of time. When smaller changes exist, line graphs are better to use than bar graphs. Line graphs can also be used to compare changes over the same period of time for more than one group. Next slide, slide 28. Heat maps. Patterns or details. When data is detailed or when patterns in the data are apparent, the use of several charts is the preferred way to show correlation. In these situations, the use of heat maps are useful as they are interpreted in a straightforward manner by the audience. Heat maps rely heavily on color to communicate values. How is a heat map chart read? When analyzing numerical data using this type of chart, the differences between low and high values are notifiable due to the varying intensities of color. The more intense the color in a cell, the higher the value. This, in essence, is how heat map should be read. For example, in 1985, among states participating in the behavioral risk factor surveillance system, 12 states had a prevalence of obesity less than 10%, and no states had prevalence equal or greater than 15%. However, in 2005, 4 states had prevalence of obesity less than 20%, 14 states had a prevalence equal to or greater than 25%. 3 of these states, Louisiana, Mississippi, and West Virginia, had a prevalence equal to or greater than 30%. Next slide, 29. And here's another example, right? Looking at, and this comes from the Urban Indian Health Institute. 10 states, if you look at the map, 10 states reported less than 1,000 American Indian Alaska Native COVID-19 cases. 2 states, Alaska with 28,000 and California with 29,432, had more than 20,000, but less than 50,000 COVID-19 cases. 3 states, Arizona, New Mexico, and Oklahoma, had COVID-19 cases counts greater than 50,000. Next slide. So dashboards. Dashboards, this is a dashboard from Johns Hopkins University. And if you notice, it goes throughout the globe and provides confirmed cases by county, region, by county and region. Next slide, 31. So what is a dashboard? A dashboard is a high-level summary displayed on one computer screen or printed page that helps viewers monitor performance and quickly identify potential opportunities for further analysis and or improvement. A dashboard is a visual display of the data of interest through numbers, pictures, maps, etc. The key to creating an effective dashboard is to understand the people who will be using it and the decisions they need to make. An example of Johns Hopkins University's COVID-19 dashboard. How many people are familiar with the Johns Hopkins dashboard? This dashboard provides insights about the spread of COVID-19, shows virus hotspots through red marks around different continents of the world. And on the side panel of the Johns Hopkins dashboard are confirmed cases, deaths, and recoveries. Automatic updates from the dashboard about the virus is supporting to the public to understand the nature of this virus. Next slide, 32. So the components of a dashboard. A chart is a sheet of information containing tables, an arrangement of data using rows and columns, graphs, a visual plotting of data to display any trends or comparisons, and infographics, a visual example comprised of charts, graphs, and minimal words to convey information in an easy to understand way. Next slide, 33. So this is the World Health Organization's COVID-19 dashboard. Notice the combined use of maps, charts, tables, and graphs. Two pictures are from the same WHO dashboard. Very effective way to display data. And we have next slide, 34, the Indian Health Service COVID-19 dashboard. COVID-19 positive cases by IHS area. You can see that it's updated every Mondays and Thursdays. Next slide, 35, infographics. Infographics tell compelling stories with data using unique design elements. They allow the audience to easily digest large amounts of information, which would otherwise be overwhelming when displayed using charts and tables. Next slide. Turning data into infographics, right? Here we have a chart, and I want to use this. Here is the COVID-19 cases by IHS area. And here's all this data that here we have all of our areas. We have what tested, positive, negative, cumulative percent positive, and 7-day rolling average. All right, so this is our table, and we're going to turn this into, next slide, 37. This is our dashboard. This is the data map by Indian Health Service area. All right, so this is the COVID-19 positive cases by IHS area. Now you have a deeper understanding of turning data into tables. And you can see how IHS uses CDC data to inform data maps. This is kind of how it's done. All tables are developed and used in some sort of graphic manner. I remember when I was at CDC on a sidebar, we would always get a table and we would turn that table into a presentation. We might even use that table and turn it into a paper. Next slide, 38. So let's create our own table from this. We can look at this data here. This is a line graph, and you can see it's the American Indian, Alaska Natives have received at least one dose of COVID-19 vaccine, and you can see all the different lines represent all the different racial ethnic groups. Next slide. And you can see by using that, we can kind of create a table. If we look at this one area, kind of the 2x2, at least one dose, American Indian, Alaska Native, and we have 77%. And you can see by using those lines, we can do the reverse and create a table. So in light of that, this is kind of our summary. I know this is very, very simple epidemiology. It's not very complex, but it's the basis for what we do with all of our outbreak response. So slide 40, please. Let me see, slide 41. Here's our NIHB contact, excuse me. Adriana Marzetti. She's the public health program manager and in charge of public health policy and programs. Next slide is my contact information. Dean Seneca, CEO and founder. I have my own LLC called Seneca Scientific Solutions. My email is thundereagle1042@gmail.com. I'm here to help answer any questions and or to work with your tribal nations, your communities, our tribal organizations, our tribal epicenters to help do more and really to protect our tribal communities, to do, I was going to say, more effective, descriptive analytical epidemiology, and to really protect our tribal communities. And our last slide there is, I just wanted to acknowledge my colleagues and students at the University of Buffalo. So, okay. I think that's it. We're open for questions. Hello?
So if anyone, oh, that's okay. So we're now open to questions. If anyone have any questions or comments, please, you can unmute yourself and ask, or you may type them in the chat box. Dean, we did have a question in the chat box. How do techs get access to data that is not publicly available from the CDC, HHS, or states? And then do you have a resource that they can go to? And Colin, you may also have an answer for this.
That is a very tough question. I think what it's important, what I try to do when I was a tech director is establish a relationship with the state health departments, have MOUs in place so that you would have a data sharing agreement with the states in which your tribal nations reside. And I think that that's probably the best way in order to get data from the state health departments. So the approach I was going to take when I was at Great Lakes is I was going to use the opioid epidemic and use opioid data in my 3 states and use that as a baseline. And I was in the process of establishing MOUs with all the state health departments, and I was going to use that, and then I would move from different types of disease surveillance. So I was going to go from use that opioid as a baseline and then start looking and maybe marching down the top 10 leading causes of death. I think that that's the best way to get data, and is this to have that good relationship with your state health department, have a memorandum of understanding in place, and that's a good way to get data and hopefully get data quickly, and get data that's not publicly available. Colin, do you have anything to add to that?
Yeah, thanks, Dean. I think that that's a great, grounded experience. And one of the things that we've definitely been sort of learning and focusing on here as we've been expanding some of the tribal epi work at CSTE has been sort of knowing and confirming that there is also a tremendous amount of education that has to be done at state and local health jurisdictions about the health authority of tribal epicenters and tribes to access data on tribal members wherever they may reside. But a lot of it does kind of come down to building connections and contacts with state health departments and directing some efforts too towards just doing some data inventories and trying to figure out who has what and where, and what are the actual access procedures for it, and really, pushing state and local health jurisdictions towards codifying some of these data sharing relationships so that it's not just taking place on like an ad hoc, individual person-to-person basis, but that these are, longstanding, regular data exchanges that take place regardless of which staff might be or not be in those particular agencies.
Yeah. And Colin, I just wanted to add to that too. You know, and my approach would have been that MOU process between the tech and the states. But also, once you showed a good relationship there, I was going to ask our tribal nations within my area to join into that MOU process. So if our tribal nations also are in the process of sharing data and or understanding or interpreting data, then you kind of really build your whole data pool within your area. So that was the approach that I was going to take, and I really wish I could have saw it through, but it seemed like it was working. It really was working. So I hope that answers your question. Oh, thanks. You're very welcome.
And to Anna's question, the short answer is not yet, but we're working on it. We're actually, one of the priority areas that we're working on is updating the tribal epidemiology toolkit that is available on the CSTE website. And then hopefully sometime around likely next summer, middle of next year, we're going to be putting out a training course on CSTE Learn, which if you're not familiar with, if folks on the call are not familiar with that, it's an online learning repository for courses and other resources on a whole variety of public health topics, but we are looking to develop a course specifically about tribal health authority, tech, tribal tech and tribal health authority and indigenous data sovereignty that is aimed, that has as its primary audience those state and local public health officials that might be, the stewards of data that you are interested in.
Yeah. Just to let you know, I do teach a working effectively with tribal governments training. I was the first person over 20 years ago now at CDC to do this training. You can contact me directly, and I usually tailor the training to the specific issues and initiatives. I've done this training with many state health departments. I recently did it here in New York, where we'll talk about, basically the history of tribes and why we're in this situation regarding these issues around data. We'll talk about public health authorities. We'll talk about the importance of addressing health disparities. I don't know if it's as specific at what CST is doing, but it seems to be pretty effective. And I'd be willing to do some, training. What I like to do when I do training is I survey the people that I'm gonna do the training for, and to kind of answer a lot of their questions, and then I'm able to put it all together in a presentation that that's applicable to the needs of the state or local health department.
So one more time, Colin or Dean or Megan, since I saw that she said she was a member, can you tell us about that tribal work group one more time and how we can join?
Yeah, sure. I'll note also, Dean has been a member of our Tribal Epi subcommittee for quite some time now. Certainly predates my arrival at CSTE. But if the Tribal Epi subcommittee is open to all active and associate members of the Council of State and Territorial Epidemiologists, but it is one of our priorities. And I'm joined on the call today by Dr. Megan O'Connell, who is our new co-chair of the subcommittee. And one of our priorities is really to increase engagement and representation of tribal health staff, tribal epicenter staff, and both expanding kind of the knowledge and understanding of some of these issues, and the building off of this movement to improve tribal data sharing efforts. So I put my email in the chat a couple times, and if folks are interested in this and are curious about how to connect, I would say just shoot me an email, and we'll figure out how to get you connected to the Tribal Epi subcommittee. If you're not a member of CSTE, I'd highly encourage folks to go take a look at our website, cste.org, and consider joining. It's really a tremendous network of, applied epidemiologists all across the country that are doing work in, all areas of public health, and is really just a tremendous resource in terms of contacts and networks and trainings and resources and everything else. That would be the best, but yeah, emailing me directly, at least right now, is probably the best way to figure out how to get added to at least to our email lists and alerted to upcoming calls, and we'll go from there. Dean, is there anything you'd like to add? I know you have some history with the subcommittee too.
Well, I just want to say I applaud CSTE for having a tribal subcommittee. I remember back in the day when meeting with CSTE back in 1999 and working with tribes was not even a thought in the organization's mindset, right? I mean, it really wasn't. And we were advocating hard back then for this tribal committee. So I want to applaud CSTE for doing this and reaching out to our tribal nations and, trying to getting as much education out there as possible about epidemiology for our tribal communities. It's a great thing. And I want to, again, and like Colin said, I want to encourage everyone to sign up and be members. And like I said early in the presentation, all my students signed up to be CSTE members, and I was really, really happy about that.
That's great. I see Megan also has her hand raised. Megan, go ahead.
Yeah, thanks, Colin. I agree with everything you both said. I just wanted to add too, particularly for this group and as the new tribal subcommittee co-chair, one of the reasons I would encourage you all to join us if you're interested is that CSTE is a leader in public health and epidemiology, and they set national priorities, by working with groups like the CDC and, having all the state EPIs be leaders in their organization. So I think it's a really good opportunity to work on data access issues and use the power of CSTE to make tribal data needs kind of part of the general regular conversation so that access can become routine, a normal part of the process. And that's personally something I'm very interested in and why I'm excited to work with Dean and Colin and any of you who will join us. But I really think that is a huge advantage. As Dean mentioned, the tribal subcommittee is relatively newer, but bringing tribal data needs and tribal public health needs kind of into this group and bringing them to the forefront where you have all these leaders in public health at the state level for sure that are talking to people at the federal level, I think is really important to do. Just kind of any way we can get our message out about what tribes need and what kind of changes they need to see, to me is worthwhile work. So that is why I do this, at least partly. And so I'd love to have you join us. I'll put my contact information in the chat once again. I know Colin can probably answer more questions, but if you'd like to contact me directly, feel free.
Let me put my contact information in there too. I don't know if that was on the slide or if everybody saw it in the presentation. So let me see. So are there any other questions? Adriana?
All right, so thank you all for coming. Again, if you would like to receive CE credits for today's session, you must sign out using this link. That is how the CE Authority awards the credits. I cannot do it. You have to use this sign out link to get your CE credits. And I really hope that at least one person found value in this presentation. And I really do hope that everyone considers the CTSTE work group. This is for our communities. This is a way for us to have a voice, to extend that voice, to hold states accountable. And this is a way to make sure our techs get access to that data. Because if we come in numbers, it's going to be hard to say no without a valid reason. So definitely consider all of that. I would also like to just put out there that the save the dates for the February Infectious Disease Institutes will go out next week. The Institute is February the 28th through March the 2nd. The CEs will be provided for all of the sessions. So if you want to go ahead and start knocking out those contact hours at the beginning of the year, this is your opportunity. The Institute is happening in Seattle, Washington. The National Indian Health Board is providing scholarships to support travel. So if you signed up for this webinar, all of that information I just shared will be shared with you following this call with the slides and the recording information that Colin shared on CSTE as well as the Institute. So without any further questions, it is 4:59. I hope you all take care. Remember, it's a triple threat out there. Do not let COVID-19, flu, or RSV damp your holiday spirit. Let's go into the new year safe and protected. So definitely drink your water. Try to keep a positive attitude, that giving spirit, get up and dance. Believe it or not, dancing is a great way to build your immune system, eat healthy, smile, and just enjoy you all's weekend. Thank you again for attending. Everyone take care.
Thanks, Adriana. Thanks, Dean. Take good care.
Thank you. Have a good one.